Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. Have you ever had the experience where, years after fellowship, you suddenly remember something that a mentor said to you when you were training and wish you could go back and thank them for passing on their wisdom? I was lucky enough to train as a fellow at the Washington, D.C. Veterans Affairs Hospital, and I remember these incredibly busy clinics every Thursday morning where we saw large numbers of patients, many of whom had OA. And one of the things our mentors advocated for was the power of physical therapy. Remember, exercise always wins. I can still remember them saying. Well, I'm happy to report those words still hold true today, and it's a great pleasure to be joined by Dr. Jamie Collins, not the NFL linebacker, but the world-renowned biostatistician. Dr. Collins is an associate professor of orthopedic surgery at Brigham and Women's Hospital and Harvard University. Welcome to the show, Jamie.
Thank you so much for having me. I'm excited to be here.
So, Jamie, you are the PI of a K Award studying data-driven approaches in defining knee OA phenotypes. And we're going to talk today about a study you recently published in Arthritis and Rheumatology, presenting the data from the METEOR trial. METEOR stands for Meniscal Tear in Osteoarthritis Research, and your paper is titled 5-Year Structural Changes in the Knee Among Patients with Meniscal Tear and Osteoarthritis. Data from a randomized controlled trial of arthroscopic partial meniscectomy versus physical therapy. A link is available in our show notes. So this is a very common problem and an important clinical question. About 90% of patients with symptomatic knee OA have concomitant meniscal tear on MRI, and the METEOR study was designed to specifically answer the question of what is the right thing to do for these patients, surgery or physical therapy. But before we get into discussing your study, there were a couple of other studies that preceded this. Can you tell us about those prior studies that laid the groundwork for the METEOR trial?
Sure. Yeah. So the METEOR trial began enrolling participants back in 2008. And prior to that, there were a couple of trials that evaluated arthroscopic surgery in patients with osteoarthritis. One that compared arthroscopic debridement to sham surgery, and one that compared arthroscopic debridement to a non-operative regimen. And neither of those found statistically significant or clinically important differences with respect to pain and function. And then there was another randomized trial published in 2007 that was very similar to the METEOR trial in that it included patients with meniscal tear and osteoarthritis and compared arthroscopic partial meniscectomy to supervised exercise. And so this study also did not find a significant difference in pain relief or functional status between the two arms, but it was a relatively small study of about 90 patients in one center. And so the METEOR trial sought to build on this prior work with a large multi-center randomized controlled trial examining this question of arthroscopic partial meniscectomy versus physical therapy in patients with meniscal tear and osteoarthritis. There's also been some observational studies that have suggested that arthroscopic surgery may be associated with a higher risk of incident osteoarthritis or of osteoarthritis progression. But in these observational studies, it's difficult to determine whether the risk of progression is attributable to the surgery or to the initial meniscal damage. And so for the current work that we did, we're trying to kind of build on the work from these observational studies and ask whether surgery is associated with a risk of structural disease progression.
I'm excited about the name of the METEOR trial. It makes me think about my telescope, but it's not about astronomy. Tell us who you enrolled in this study and what you were trying to assess.
We are well known for our acronyms over here. So the METEOR trial enrolled participants who were at least 45 years old, and they had evidence of meniscal tear on MRI and evidence of osteoarthritis on either MRI or X-ray, and also people who reported knee symptoms lasting at least 4 weeks. So looking at sort of that chronic knee pain versus kind of an acute injury. And participants were randomized to arthroscopic partial meniscectomy or APM with a postoperative physical therapy regimen or to just the standardized physical therapy regimen without surgery. And the main trial outcome was physical function at 6 months. And so that main trial result did not find a difference between the two treatment groups in that primary outcome of physical function at 6 months. But the current paper looks at a secondary outcome, which looked at structural disease progression in the joint. So things like cartilage loss, osteophytes, and markers of inflammation.
And as I understand it, you didn't blind this study, correct? So if people received the surgery, they were aware of it, obviously, and those who didn't get surgery didn't have any kind of sham surgery. They knew they were getting PT alone, correct?
Right, right. So patients and providers, the surgeons, physical therapists were unblinded. And I think this is like a really good point. When the trial was being planned, the investigative group didn't really consider sham surgery feasible. The surgeons were sort of uncomfortable with the idea of conducting a sham surgery. And they also felt that patients wouldn't accept randomization to a sham procedure. So, they thought we might have difficulty enrolling if kind of the control arm were a sham procedure instead of just this non-operative regimen. There are also questions about kind of the billing and legal aspects of doing a sham surgery. A lot of the sham trials have been in Europe. And so the patients were not blinded, providers were not blinded, but in the current study, the outcome was structural progression as assessed on MRI, and the radiologists reading the MRIs were blinded to treatment group.
Okay, so tell us a little bit more about that MRI analysis. How did you break down specific components of the MRI to evaluate change over time, and how did you categorize those changes?
Right. So the MRIs were read by expert radiologists according to the MRI osteoarthritis knee score, or the MOAC system, which describes key features of the joint. So things like cartilage surface area, cartilage thickness, osteophytes, synovitis. And in this system, the knee joint is divided into subregions, and each subregion is scored on an ordinal scale for 0 to 3 for a given feature. And so we looked at change for each of these features separately and did this in a couple of different ways. There is really no sort of consensus for the best way to kind of handle these data. And so this is a similar approach to what we've done in some prior analyses, in that we created a summary score by simply summing those ordinal scales across all subregions for a given feature. So, for example, osteophytes are scored in 12 locations. And so if you sum across all locations, you could have a total score ranging from 0 to 36. And so this approach has the benefit that it's easy to interpret and it's easy to analyze. You end up with sort of a nice continuous score, which is easy to do in linear models. But the downside is that we lose some of that nuance of the subregion specific scores. And so we're sort of just summing across the whole joint and we lose a little bit of the nuance. So we also looked at change within subregions and counted the number of subregions that had worsening. And so we tried to come at it in these sort of two different ways to try to get at both sort of the overall kind of joint damage for a given feature and then kind of the subregion specific damage.
Great. And so, from your background as a biostatistician, can you tell us a little bit about the analysis of this data? And in particular, could you help us understand the nuances between the intention to treat and the as treated analysis in this study? I guess it looked like from the manuscript there are a few patients who switched arms, and you maybe can give us your thoughts on that and why this happened and how you managed it in the analysis.
Yeah, you're right. So there's a non-trivial amount of crossover in this study, which is actually fairly common in these sort of unblinded surgical studies. And many other trials in this area have had similar crossover rates. And in the situation where there's sort of a substantial amount of noncompliance or crossover, it's recommended that you do both an intention to treat and an as treated analysis. And in the METEOR trial, participants randomized to physical therapy were allowed to cross over to APM if the patient and surgeon thought it was clinically indicated. So, we're not going to tell a patient who's tried physical therapy, who's still in pain, who's still having trouble, you're not allowed to get surgery. It was up to the patient and the surgeon to decide if that was sort of the right move. And about 30% of those randomized to physical therapy ended up undergoing surgery. And then, a handful of participants randomized to surgery, about 5% didn't end up going the procedure. So again, when they agreed to participate, they said that they'd be willing to be randomized, but sometimes, you call that person up and say, okay, you're gonna go undergo surgery. Some people had second thoughts. And again, we're certainly not going to force anyone to go through with something they don't want to go through. So we looked at it both ways in the intention to treat and as treated. And so in intention to treat, participants are analyzed according to the randomization group. So irrespective of what treatment they actually received, you get analyzed according to how you were randomized. This is a pragmatic approach that reflects the range of events that might occur following a treatment decision in clinical practice. And the important part is that this maintains the balance of potential confounders that we achieve by randomization. But as we sort of touched on, the results of the ITT analysis are affected by this sort of trial-specific pattern of adherence. And so they show the effect of treatment assignment on outcome, but not necessarily the effect of treatment on outcome, particularly when 30% of one of your arms crosses over to the other side. And so the second approach we took was this as treated analysis, where participants were analyzed according to the treatment they actually received. And the aim of this is to estimate the effectiveness of the treatment actually received. But the concern here is that, with the as treated approach, we've sort of disrupted that balance of confounders. The whole point of randomization is that we balance the two groups on both measured and unmeasured confounders. Once we start sort of mixing those groups up, we lose that balance achieved by randomization. And you start having concerns of, who are the types of people who crossed over? Are they different from the people who didn't cross over? And do we need to sort of consider adjusting for characteristics that might be associated with that? And so, that decision to comply with a treatment protocol might not be at random. And so when we're doing the as treated analysis, we have to think about things like confounding that you typically don't worry about so much when you're analyzing results from an RCT.
Yeah. And you also had a few issues encountered with missing data, I guess, again, not uncommon with a large, complex, multi-center trial. How did you handle missing data, and why is that important as we look at this analysis?
Yeah, so our current analysis looks at outcomes at 5 years post randomization. And so by this point, there is quite a bit of attrition. Our primary outcome is the structural disease progression is assessed on MRI. So often, even if we could get in touch with patients and have them fill out questionnaires, it was more difficult to get people to come in and actually undergo an MRI. So about 3/4 of our participants had an 18-month MRI, but when we get out to 5 years, we're only at 56% of the original cohort. And so that concern is that, is that 56% really representative? Or do we think that certain types of patients are less likely to have completed the 5-year follow-up? Maybe those with worse pain are less likely to come in. Maybe patients as they get older and retire and move to Florida, they aren't going to come in to our Boston clinic to get an MRI.
Well, maybe they got better.
Right. Well, that's the other thing. Maybe they got better and they don't want to hear from us. They're doing great. They're playing tennis and skiing, and they're too busy to come in. So we really don't know, right? And so the question is, if you just look at those people that you have data on, is that really representative of the whole cohort? And so we have to think about how we handle that. And we also have to think about, what we call informative missingness, which means that, the reason that the data are missing is actually related to the missing data itself. And in this particular case, we were concerned about missing data due to total knee replacement. So over this course of 5 years, I think around 7% of the cohort ended up undergoing total knee replacement. And having a knee replacement really precludes the assessment of any imaging-based measure of structural worsening. You have a new joint in there. You can't actually go in and sort of score the joint for these structural features. But you can imagine that those people who progressed to TKR would have had worse structural progression than those that didn't. We just haven't been able to observe it because they underwent this surgery. So for that reason, we used a few different techniques to handle the missing data. For those continuous outcomes, we use linear mixed effects models, which can handle unbalanced longitudinal data, so everyone doesn't have to have the same amount of follow-up visits. And this approach is really good when we think the data are missing at random. That means that the missingness can depend on data that we've already observed, but doesn't depend on data that we haven't observed. So you can kind of make a reasonable guess at what you might have observed based on the data that you already have. We also did multiple imputation, which is a sort of similar idea where we imputed the missing follow-up data based on the data that we already have, so based on observed outcomes and covariates. Neither of those really get at that question that we were concerned about with total knee replacement, though. So as a final sensitivity analysis, we did multiple imputation, assuming this sort of not at random missing data mechanism. And so what we did was we imputed data for those who were missing follow-up because they underwent TKR, and assumed that actually their outcomes would have been worse than what we would have predicted based on the observed data alone. We assumed that if you progressed all the way to TKR, that you actually probably had worse structural progression than we would have predicted if we just looked at what we observed. And so that was kind of the final way that we tried to get at whether these total knee replacements were sort of an informative missingness.
So that's fabulous, and I'm glad you explained that to us. So with all of those factors in mind, can you tell us what you found in the analysis of the data?
Sure. Yeah. So both groups exhibited worsening across all of the domains and time points. Interestingly, the progression was more pronounced in that first 18 months after randomization than from the 18 to 60 months after randomization. And I should pause here and just say that we had MRIs at baseline, so right before randomization, at 18 months post randomization, and then at 60 months post randomization. And so we looked sort of separately at those two time points, progression over those two time points. Over the earlier time point, we found that the surgery group had significantly greater worsening in cartilage surface area, in effusion synovitis, and in osteophytes. But interestingly, when we look at the later time period, 18 to 60 months, only progression of osteophyte size was significantly greater in the surgery group. Results were generally robust across the various definitions of change and in our ITT and as treated analyses. So, sort of more differences in that earlier time period that seemed to level out in the later time period, with the exception of osteophytes. And what's interesting is these results are similar to some recent data that's been published of some other sort of similar trials, which have found this osteophyte progression being sort of enhanced in the surgical group.
So that's interesting, and kind of suggests to us as clinicians that we should perhaps be a little bit more circumspect about consulting orthopedics for meniscectomy in these patients. And as we counsel our patients, perhaps be a little bit more thoughtful about caution with regard to surgery. I'm wondering, did your group look at all at the clinical outcomes, particularly pain, and then obviously the ultimate need for knee replacement surgery? Did the surgically treated patients have improvement in pain or function? And is there any way to assess compliance with the physical therapy in these patients? And could that have been a confounder in your results?
Yeah, so we did look at this, and this was published in 2020 in Arthritis and Rheumatology, where Jeff Katz was the first author. And so we looked at pain and function and knee replacement over that 5 years of follow up and found that the pain scores improved substantially in both groups, the operative and non operative groups, over the first 3 months. They continued to improve actually up to 2 years post randomization. And then we're generally stable from 24 to 60 months. So I think patients in both treatment groups actually had really quite good outcomes all the way out to 5 years. From the total knee replacement perspective, as I said, about 7% of the cohort underwent TKR in the index knee over this 5 years of follow up. What we did find was that from an as treated perspective, only about 2% of those subjects in the physical therapy group underwent TKR over 5 years, compared to about 10% of those who underwent surgery. And so we did find sort of total knee replacement to be more common in those who underwent surgery compared to those who did exercise alone. We have to be a little bit cautious in how we interpret that. Is it actually that the surgery is sort of causing joint deterioration, which is causing patients to need knee replacement? Or is it that, those patients who came in and had arthroscopic partial meniscectomy, they underwent one surgery, they sort of have a relationship with an orthopedic surgeon, they feel more comfortable with surgery, and maybe that's just part of it. If you have a good experience with the first surgery, maybe you're more likely to sort of be willing to do the second surgery. So we want to be cautious in sort of a causal interpretation of that. But we did find, about 2% of those in the physical therapy group undergoing surgery compared to about 10% in the surgery group.
Yeah, I like your caveat there.
Yeah.
I can tell you're in the Department of Orthopedics.
Right. We don't want to have everybody, we don't want to have orthopedic surgeons mad at us. And maybe that's it. Maybe they just love their orthopedic surgeon and can't wait to come see them again. But interestingly, you bring up a good question about sort of physical therapy compliance and how compliant were patients, and maybe if everybody had really stuck to the regimen and did everything they were prescribed, would the results have been different? And that's something that you can get at with a per protocol analysis, which is where you only include those participants who actually received the treatment as outlined in the protocol. And we haven't done this in part because the adherence data is a bit difficult to interpret and can be sort of difficult to measure. And Meteor research staff called participants and asked them about whether they attended their in-person PT sessions and what their home exercise compliance was. We didn't get very complete data. Actually, almost 10% of those in the exercise arm just never answered our calls and didn't tell us anything about their compliance. And so, for that reason, we didn't try to do this per protocol analysis, but as best we could figure, about 40% of those in the exercise group were less than 50% adherent to exercise. And this was data we published back in 2016. So I think, thinking about a per protocol analysis, and is it that the reason that exercise didn't look better is because people weren't compliant with it? I think it'd be an interesting thing to do. And I think, going forward for trials of exercise, really thinking about what is the best way to measure compliance with both in person and with home exercise. And there's some creative solutions out there, but yeah, I think that's an important consideration if you want to do a per protocol analysis.
Yeah, and I mean, technology has advanced in the time you were doing this study too, right?
Right. You think about, having a research assistant sort of, call people at home. Now we have automatic surveys, we can send text messages. So, from when this study was designed back in the early 2000s to now, I think we've got a lot better ways to really try to get in touch with people.
Yeah, now you could measure it using their phone or their Apple Watch or whatever and see how much they're really walking up and down the stairs, right?
Right, exactly. We're actually planning a trial now looking at improving physical activity after joint replacement. And we're going to give people Fitbits to wear so we don't have to rely on what they're telling us. We can actually measure exactly what they're doing. So, yeah, the field has come a long way in the last decade plus.
I actually think about that a lot, that it is impressive how much our field has advanced, but yet those words of my mentor back when I was training, which was a while ago now, still ring true that, you got to move and it's the best thing for your joints if you just keep moving. And that sticks with me.
Yeah, yeah. And I think, the results of Meteor and of other sort of similar trials, I think have really helped to inform guidelines, which suggests that, exercise is really the first line therapy that people should try. And it works for a lot of people. We had that 30% of patients approximately crossed over from exercise to surgery. But that means 70% of people did really quite well, even all the way out to 5 years with just exercise alone. And so that idea that this is what you should try first, try this non-operative regimen, strengthening, stretching, getting some activity. And then if that doesn't work for you, then yeah, let's talk about surgery. Let's talk about what the other options are. But this idea of kind of exercise as the first line treatment, I think is something that Meteor and other studies have really helped to inform.
Yeah, I completely agree. And I really appreciate how well written this manuscript was, how you've been able to present this really complex analysis in a very understandable way. And I want to thank you for joining us today. And I hope you'll excuse the pun, walking us through this very. So I like at the end of our interviews to give our listeners a little bit of insight into the people behind the paper. And so I wondered if I could ask you a few questions about your career.
Yeah, sure.
After your master's in mathematics, you were working for a consulting company as a statistical programmer. What prompted you to return to academics to pursue your PhD, and how did you end up interested in studying arthritis?
Yeah. I love working with data. I loved programming. I learned a ton. I worked for about 5 years as a statistical programmer, analyst, data manager. But I really wanted to be able to ask my own questions and sort of design my own analyses. And so, because of that, I decided I wanted to go back and get a PhD, get a bit more training, and then sort of be qualified to do that, to write my own grants, come up with my own ideas, design my own research question, which is a little bit scary now that I now that I actually have a K and have to do it. I kind of think, oh, why did I want to do this again? But it's a lot of fun. It's a lot of fun to get to really come up with your own ideas and then write a grant and pursue them. So it's a lot of fun. It's exciting, and I feel like I'm continuing to learn every day, and I still get to do the fun part, which I think is the fun part anyway, which is, just working with data. I sort of, just fell into this opportunity to work in arthritis, but it's been a really interesting experience for me. My grandmother actually had really terrible hand osteoarthritis. She was a seamstress. And I just remember how debilitating it could be. And so, arthritis is one of these things that sort of, I think people think about as this inevitable thing that happens as you get older and sort of not really something to be concerned about. But actually, when you talk to people with arthritis, when you look at the results of some of these studies, even in the Meteor cohort, I think that the average baseline pain was around 50 on a scale from 0 to 100, which is, really quite a bit of pain for people to be living in every day. So that it is, a sort of a serious disease, and it is very complex. And I think that lends itself to some really interesting analytic questions and analytic approaches. So it's been a really interesting and fun experience getting to know the disease and to think about different ways that we can study it.
Yeah. And I think your description of the PhD pathway being long and arduous is real. Some have likened it to a long, cold night on the side of Mount Everest. I wondered, can you share any words of wisdom that you've learned along the way, particularly for those listeners whose work is, like yours, very dependent on interdisciplinary collaborations? Do you have any recommendations for either non-clinicians collaborating with clinicians, or perhaps the reverse, for clinicians collaborating with biostatisticians?
Yeah, I think my advice would be to be really clear from the beginning about what the research question is and to make sure everybody is on the same page. I think a lot of frustration can happen when the statistician and then the PI are sort of, they think they're in agreement about what they're doing, but they actually are totally on different pages. And that's happened to me before. And so what I've liked to do is really to put together an analysis plan before I even touch the data, and make sure everybody is on the same page about what the question is, what analysis we're going to do, and sort of what question that analysis is going to answer. It's really amazing how much can get lost in translation. And I think having the plan down on paper can really help everybody to stay on track and to understand each other.
Yeah, completely agree. Yeah, it definitely prevents confusion later on, for sure. So finally, any mentors who inspired you on your journey? And could you tell us a little bit about those experiences?
Yeah, I'm really lucky to have two incredible mentors here at Brigham and Women's, Elena Lostina and Jeff Katz. Elena is a biostatistician. She was my PhD mentor. And Jeff is the PI of the METEOR study, and he's a rheumatologist. And so, talking about that clinician-statistician collaboration, I have sort of the best example of it here with my two mentors. They've been a wonderful example of working together, complementing each other's expertise, sort of knowing when you need somebody else's expertise. I'm not a clinician. I didn't go to medical school, recognizing that there are sort of deficiencies in my understanding that I need somebody with that expertise to fill in, and sort of vice versa. So I've learned so much from working with them. They both dream big, which can be a little bit scary sometimes when they propose things. I think, oh, wow, you must be totally crazy. And, undertaking a trial like METEOR is really scary and intimidating. Patients were enrolled at 7 centers. Half were going to be randomized to surgery. We needed to get people in for these imaging studies. It's sort of an audacious thing to propose. And it was a massive undertaking. But I think when you have a really good team around you that works well together, and you make sure that everybody sort of knows what they're doing, is on the same page, these big projects don't seem so scary. So I've been really fortunate to have these great examples here at Brigham.
Yeah, no, and I must say for many years they've been kind of inspirational to the whole community of rheumatology. So thank you definitely for sharing that. And I really appreciate you joining us today, Jamie, and sharing your work. It's been a pleasure to have you on the show.
Yeah, thank you so much for having me. And I really appreciate being here and getting the chance to talk about this work, which was a huge collaborative effort, if that wasn't clear from how I describe METEOR as a scary, audacious undertaking. There's a huge list of investigators, research assistants, surgeons, physical therapists who were all so instrumental, not just in, carrying out the trial, but in helping me with the analysis and interpreting the results. And so again, it's just a great team to be a part of. And I'm grateful to be here and get to share our work.
Oh, fabulous. It's really been a pleasure listening to you talk about this amazing study. So I appreciate you joining us today. I want to close this episode by thanking Wiley, the publisher of the 3 ACR journals, Arthritis and Rheumatology, Arthritis Care and Research, and ACR Open. These 3 peer-reviewed publications publish cutting-edge studies focused on pathophysiology, treatment, and outcomes of rheumatic diseases, and we're grateful to Wiley for their support of our field. Thank you also to our listeners to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Rheum on Facebook and Twitter, and please rate and subscribe to our podcast at acronair.org or wherever you get your podcasts.